You've already heard some pieces of discussion on the topics they're going to talk about, and that includes the integration of behavioral health and how we might address our opioid public health crisis in the state of Montana. So my welcome to Dr. Gregory Holzman, who's a medical director at DPHHS, the Department of Public Health and Human Services, our Attorney General, Tim Fox, welcome. Aaron's coming back, Dr. Wernham, thank you for coming back this afternoon and being part of the conversation. And we're going to hear from Craig Osved, who is also going to moderate this panel.
Well, thank you, and thank those of you for hanging in there. Tough being the last one of the day, but this next topic is obviously very near and dear to my heart. As the CEO of HealthCare, I see this next topic played out every day, and it continues to grow and increase. So rather than me sitting here talking about HealthCare, I'll turn it over to these panelists, but I will just tell you, for example, at HealthCare, 99% of our kids are from Montana, and we are always full and a frequent waiting list. And just as an FYI, today we had 35 kids on our waiting list trying to get into HealthCare. So with that, I think everybody has copies of your these gentlemen's bios in your packets, and I'm going to turn it over first to Attorney General Tim Fox. Thanks.
Thank you, Craig, and good afternoon, everyone. Thank you for sticking out the whole day here, particularly when the weather's been a little bit fickle. I'd like to thank the Chamber for inviting me to participate in this panel today. I'd also like to thank my co-panelists here, individuals who are very dedicated to making sure Montana is healthy. And it's been great to work with them and their agencies and organizations here over the last number of months on some very important topics. I want to real quick give a shout out to one of our local legislators, Senator Mary Cafaro. I was not surprised to see her on the agenda and see her here today. Those of you who know her know she's very passionate about Montana and the work that she does, and she comes to everything. She's learning constantly, educating herself, and then she's advocating, and that's the kind of legislator that we want to have in our state legislature. So thank you, Senator Cafaro. I think that's worthy of a round of applause too. And there are others like her. She's not the only one, but she is a hard worker. You probably already know this, and you've talked a little bit about today, but Montana's substance abuse problem has really reached frightening levels, and I would entertain the fact that I believe this is probably one of the larger crises. We have a budget crisis. There are lots of different things that happen in our state that we had lots of fires this year, but by far and large, the substance abuse issue, I think, is probably one of the greatest crises that we've seen in our state in a long, long time. And it affects everybody in every aspect of our lives. But the business community in particular experiences significant negative impacts from substance abuse. So it's very encouraging to see so many of you here today who are ready and eager to tackle the health care challenges facing our state, including substance abuse. So our panel this afternoon is to discuss behavioral health and opioid use, but I think it's really important that when having discussions like this, we don't limit our focus to only one or two substances in particular. Substance abuse and addiction are driven by a wide variety of substances, both legal and illegal. And when discussing comprehensive solutions, we must really talk about all aspects of the problem, because if you're in law enforcement or healthcare, or the juvenile justice system, or the youth in need of care program, and the list goes on and on, Department of Corrections, Public Health and Human Services. You understand this is a kind of a revolving door situation, and it's not just about opioids, it's not just about alcohol, it's about all of the above. So I'd like to begin by mentioning a few statistics that outline the scope of the substance abuse problem in Montana. Since 1980, the drug offense rate in Montana has increased 559%. Methamphetamine violations are up over 500% in just the past 5 years. 1 in 5 Montana adults report binge drinking in just the last month, and that is way above the national average. From 2010 to 2014, the total charges in Montana for the ER and hospital visits with a primary or secondary diagnosis of substance abuse totaled $796 million. 48% of suicide victims in Montana had alcohol in their system at the time of death. From 2013 to 2016, the state crime lab experienced a 143% increase in substance samples testing positive for methamphetamine, making it the most common drug found in tests conducted by the Montana Crime Lab. In 2016, 53% of the Montana Department of Justice Division of Criminal Investigation Narcotics Bureau investigations involved methamphetamine. And heroin violations have increased 1,557%. That's 1,557% from 2010 to 2015. So as you can see, Montana suffers from a variety of abused substances with significant statistical increases in the presences of substance abuse and substance abuse-related crimes in recent years. So what are we going to do to address this problem? Now, many organizations have been doing a lot of great work and working tirelessly on many of these issues. But I think one of the things we've been lacking a little bit, and I believe my colleagues would agree with me, is collaboration, communication, comprehensive approaches, and a deep down look at just really where we are, what we're doing, what works, what doesn't work. And so that's why in April I announced a new program from our Department of Justice called Aid Montana. So a little background on Aid Montana. We call this Addressing the Impact of Drugs, but there again, it's actually about substance abuse, but we couldn't come up with a perfect acronym, and we finally agreed on AID, Addressing the Impact of Drugs. But keep in mind, this is substance abuse. And it's aimed at developing a comprehensive strategic plan to combat Montana's growing substance abuse crisis. This plan will be a comprehensive approach to addressing substance abuse in Montana, and while law enforcement will certainly be one method of addressing substance abuse, it certainly isn't the only approach. Treatment, education, and coordination efforts are critical if we are to get ahead of this problem and will be central components to our strategy. In September, my office released a landmark report on substance abuse in Montana, including a map of current state efforts aimed at addressing substance abuse. If you will go to www.dojmt.gov, dojmt.gov, you'll see an Aid Montana icon, and click on that and you can see the report that we issued. I would hope that obviously all of you are very motivated individuals and interested in these subjects, that will be something that you take the time to read. As part of the Aid Montana initiative, my office has partnered with other government agencies like DPHHS, and Dr. Holtzman and his crew have been very instrumental in getting information and starting new programs and looking at alternative ways to address these issues. And so I want to thank you and DPHHS for all of your work. We also partnered with the Montana HealthCare Foundation to hold listening sessions across the state. And let me be clear, it's not like one day in April we came to Aaron and said, could we get the HealthCare Foundation on board on all of this? They were already doing a lot of great work. This is something they identified as a priority as well. We did these listening sessions across the state, and we then just recently held a day-long summit here in Helena to talk about some of these issues. It's important to keep in mind that government can't address the problem of substance abuse alone. Any effective solution will include partnerships with the innovation and resources of the private sector and the nonprofit community as well, and really simply just people, Montana people. If we're anything, people in Montana are compassionate. They care about their neighbors. They're engaged typically as a whole. And I have every confidence that working together at every level, including individuals who just want to leave things better than when they found them, we can get a handle on this. So the solutions can't come soon enough. I bet you if I took a show of hands at how many of you know someone, had a family member with a substance abuse problem, and maybe some of us in this room have had it or do have it, but the number of people that we've lost over the last number of years, it's really affected everybody in this room, I would venture to say. And we're going to have to do everything we can to get ahead of this crisis and get it under control. And while there will always be those who allow politics to cloud their vision of what's important when it comes to addressing Montana's growing substance abuse problem, I believe we all must take the high road. And what I ask most folks to do when I speak about this is, you have your area of expertise, your area of engagement, your area of interest. You or your organization have your missions, your goals, the ways in which you might help on this issue. And I would ask you to learn what others are doing, what someone else is tackling, how they're contributing to the overall picture, and grow an understanding of the full picture so that we can have a better understanding of what's going to work, where we may have to shift resources, what our priorities must be going forward, because it may not be your priority. It may not be your organization's priority. It may be something else. And in this day and age of, particularly as it comes to government, in budget crunches, which we've just gone through, and the legislature's out of town, at least some of them anyway, the reality is that we're probably going to have to do more with less. And how do you do that? You become more efficient, you become more focused, you have a better understanding of where you can be effective. So let's roll up our sleeves and put politics aside and come together and get that comprehensive, collaborative plan that really has to be nimble, because the landscape changes almost overnight, whether it's the kinds of drugs that are coming into our state, the new prescription drugs that might be introduced, the social and societal pressures that we may see. We have to be adaptive. And lastly, I would say we have to be better at communicating to the public that people who experience a substance abuse disorder are worthy of our love, our care, and we need to take care of them. We need to make sure that they have every tool necessary to recover. They are victims. They're not criminals. They didn't set out to be criminals, those that turn to crime. And so we have to raise the public awareness. And as Montanans, we do it best. We need to be compassionate. And so I know that all of you will be committed to doing that. We're going to leave a few minutes for questions at the end. So I look forward to working with each and every one of you. Contact my office if you have ideas, or if you want to be more fully engaged. Contact the HealthCare Foundation or DPHHS because they would love to have your assistance. Thank you very much.
Thank you. I got to tell you, sitting here, I was at the very beginning and I had to leave for a little while, and then came back and listening to the speaker that was before us. I like those type of speakers because I think it really makes us think. At the same time, I won't say I agree with everything, but it does start the conversation. It also kind of depressed me because I was sitting there thinking, well, I guess my job doesn't matter anymore. And I quickly came over that, and I do think there's some really unique things that we can do, and we are doing in Montana, and I think there's some uniqueness about Montana just because of our size. Everybody says this quote. I'm going to make the quote too. You know, we're a small town with long roads, but it does those personal connections. And I do think money plays into things, but there's also other things that we want in our lives that we quote unquote buy, whether that's with financial things or with our compassion and caring for each other. So with that in mind, you know, I don't have any conflicts of interest, I can say that, except that I do bleed in public health and the social services, because if you do look at, and I would have some discussions on some of that when we look at a cross-cultural, the OECD comparisons between countries, one thing that you will see a lot of is where the funding and the coordination with some of those services, and we always talk about the social determinants of health. So that kind of takes me up to the substance use disorder. It's a devastating disease, and we've seen it destroy individuals, we've seen it destroy families, we've seen it destroy communities. And we often look at it and sit there and say, okay, what are the root problems here? How can we do this? And we talk about poverty, and we talk about lack of family involvement. We talk about untreated mental illness or exposures to highly addictive drugs. We talk about ACEs, adverse childhood events. We even talk about as they call the new public health issue of loneliness. All these things that play into it. And we have people working on that. I would say a lot of it's underfunded and not coordinated as well as we could. But we do have people, both public and private, all sorts of different areas working on that. But sometimes I think it's important also, especially with the financial things that we're talking about, is kind of, they say, turn the iceberg or see it as a tree. Those are the root of the problems. Put substance use disorder in the middle, and then start thinking about the branches of the effects that this has on us. And we start to see how much of this effect of substance use disorder has on all sorts of things. So Attorney General Fox talked quite a bit about the crime areas things. We have one of the highest rates of drunk driving or fatalities secondary to alcohol. And as you know, our number one, by far, substance of abuse in this state is still alcohol. Methamphetamine has been increasing, which is very concerning, and of course opioids is much higher than it was in the 90s in Montana, but not luckily as bad as it is in some states like Ohio. But we see how it's affected the criminal child abuse and neglect, property crime, all these other areas. We see how it's affected our law system with our overcrowded jails and prisons. We've seen how it's affected public health with increases cases of HIV, hepatitis. With HIV, we haven't seen increases here. We have seen increases of hepatitis C, STDs, and also the money we spend on outbreak investigations. And one thing that we don't talk a lot about but does have a big effect and kind of continues with it is the unplanned pregnancies. And we have a new data set that we just got a grant for that will start being able to look at that a little bit more. It's not really just the unplanned pregnancies that we worry about, but it's the unwanted children. So it's another way to look at. We talk about the healthcare costs, and we're starting to see this endocarditis secondary to IV drug use, or just abscesses that people are showing in, or to the emergency rooms dealing with the overdoses. We talk about the social services that we have to try two things, the increase in foster care need, and that was brought up about 65% of the kids in foster care, parent being removed because a parent has a substance use issue, child endangerment, and then it kind of goes right back to those roots again. Some of these things lead right back to the, untreated mental health issues, treats to unemployment, to homelessness. And so we kind of go in this circle. And so the question started to be, what can we do? And what can happen here? And we know we have limited resources, but could we align our systems a little bit better? Could we collaborate better? And when I say that, I'm not talking about within government, although I think we've done a really good job. For somebody who's worked in another huge bureaucracy, in Michigan, which is 10 million people, I'm amazed that I talked to the Attorney General, okay? That's amazing that we have that cross conversation and the amount of work. One of his employees, he and I send articles back and forth and talk all the time, and it's been a really, really wonderful way of collaboration and communication, which I think has made some big differences. So we start to look at that, and how do we start to do this? We know we have limited resources, and how we've reached out to the Montana HealthCare Foundation, and they've been very helpful in helping us get especially one grant that we had, and they've been helping quite a bit on these different programs. We got 2 grants that has really helped us start this movement of coordination across that. We have a CDC grant that we got for $300,000 for 3 years, and then they just threw in an extra $240,000 last year, and we're really hoping that's coming again. And then we've got a $2 million grant from SAMHSA for 1 year, and then they just increase that for a second year. One thing that we do know, a lot of money is drying up from the federal government, but a lot of money is coming in for opioids. And while we know legislation is probably never going to send us money for infrastructure, which is what we desperately need, but it's just things come in silos, and that's just how it's done at the federal government, it's how it's done at the state government. But we have to use that money in a creative way to build systems honoring the grant. We got to make sure we follow the rules of the grant, but that we can see as something that could work in an even bigger perspective. And that's what I think we started to do. I'd highly recommend, this is the Surgeon General's report that he was talking about, to go to his website. I think this is an awesome document. It's really, really good to look at it and see where we are right now. They did a fantastic job of that. And for somebody who comes from the health field, it was really educational for me to learn the other side. I had all my, conceptions and everything. This was really helpful to at least make the conversation, we started on the same ground. And this is a great document, and I highly recommend people to read that. With the grant, we put together a document, and when I say we prepared the document. It's been 82 different agencies, I think over 114 people, and we're still looking for more if people like it. I highly recommend you to read this. I would say read the Attorney General's document first. And this is a strategic plan for us to start to coordinate. How do we respond to this in an organized fashion? How do we start to bring things together? There's a lot of interesting projects that are happening around the state that I don't think other people know about. And one thing we can do is help pass on the good information that's happening. We also need to do evaluations so we can test what is working and then adapt if it's not working. I think we've started to do other things. When we broke up the areas we wanted to work in, we talked about monitoring being one, and I think these two start in the aspect of monitoring and give us some objectives to look at and some metrics to follow. The other things we decided to do is we decided we needed an epi group, but not an epi group of public health or something like that. We needed to bring in all the different data sets that we were looking in. So we have public health sitting on this epi group. We have Children and Family Services. We have AMDD, Addiction and Mental Disorders Division. We have Medicaid on it. We have Department of Corrections on there. We have Department of Criminal Investigation. All of them have different data sets, and we can start to look at these together to get a better picture of what's really going on. And we took the data that we learned from, as we put together at the state, a state health assessment to look at what are our major health problems that are going on around the state. In that, and this was funded by the foundation, they helped with a lot of the communities around the state to do community health assessments. And this hospitals that are under the ACA and getting IRS, they have to do a community health benefits, a community health needs assessment. And looking at those things and pulling it up from all the different counties that have done that, 2 things that are in the top 4 every single time is mental health and substance use. So this is the issue that if we can make a big difference, we can make a big difference along. So that's kind of the monitoring area. We started to say, what can we do in prevention, and how do we coordinate that better? So again, we look in prevention. We look at some population-based things. There's some interesting things that have worked overseas. It will be interesting to see how they work here. The Surgeon General, who was here last week, brought it up, the good behavior game, which helps work on resilience and some other things with the young children. We've done little things like the proper disposal of medications, from what the Attorney General group's doing with the take-backs to also the deterra bags that have gone out to different areas to help get rid of the medications that's been going on. We have other things like naloxone, as we talked about. A great step to give a person a second chance at life. And we're getting that out to first responders, to police officers, to firefighters, etc., and people in the community can go and get naloxone. So all this is helpful. And then we're trying to do some other things. This, again, I think Aaron might talk a little bit more, and we're working in partnership with him, which I would say fall in prevention, but kind of moves over a little bit into treatment, and that's the SBIRT, the screening, brief intervention, and referral to treatment. I think a lot of my colleagues in clinical medicine get really caught up real quickly at the referral to treatment and start to get scared saying we don't have enough resources for that. But what we find from SBIRT is a lot of it can be done in the clinic, and actually we can prevent things from going down the line to worse situations. Big aspect that we're using that SAMHSA grant that we're getting so much money for, we use some of that to buy some of the naloxone to get it out to the first responders. We've used some of it for the Datura bags, but the main point of this is to build a hub and spoke model. And this hub and spoke model is to build, we have 6 hubs that are going to become the experts with medication-assisted treatment for opioids, which is the evidence-based standard of care at this point in time, to do better on those on treatment with that. But they will work out with spokes so that we can have a continuing aspect, that then when they go back to their communities, they have providers that can continue to care with them, that we have community health workers that work with them to make sure that they get the services that they need. And if they're falling back, that they have the expertise back in the hubs that can help them work with these individuals, so that they don't go into inpatient and then just be back out on the streets and start again. So we're looking at different ways to do that. We want to look at evidence-based treatment that really works, and I won't say always evidence-based. We'll also look at promising practices, but we want to evaluate it to see if we're making a difference, and then if we're not, make the changes that are going on, but to continue to do that. And the other area that I'd say we're really working, and the other idea about the hub and spokes, is that how do we take the few psychiatrists or the few experts we have in this area and not burn them out? We don't want to lose the people that we do have. We want everybody to be able to work to their skill set and up to that level, and then kind of wrap around the services so there is much more of a team approach. An integrated behavioral health that we've talked about so much in so many other areas, this is one of the areas that we can continue to start to build that. And the last thing I'll bring up is recovery, and there's a lot of things that come into that, but it kind of goes right back to those root problems that we've talked about. We get somebody helping them, we get them in the right direction that they've wanted to go. As the Attorney General talked, these people want help. Most of them, this wasn't their area that they wanted to go. It's a chronic disease. But peer support, people that have been through it that can help them through these situations and walk them through and keep them to help them through the challenges that will be ahead. But something the Surgeon General brought up last week, which I had never thought about, and it was like, that's a great idea, is to use that peer support also when they come into the ER and we can't get them into treatment. When it's we get that teachable moment, we can get them, they want treatment right then, they just had a bad situation, and then we say, here, call this place, and they can't get in for 4 weeks. If we can get them with a peer support that can help them through that time, as we continue to work at ways that we can get them into treatment faster, that would be great. And also, there's been a lot of things that I've learned as I've started to learn more about this, that individual communities who've just gotten fed up and said, we got to do something, are doing some interesting things. Now we need to coordinate it across different areas. There's an ER doc that I just learned about in the Billings area and Livingston who just decided they've had too many problems, that they started to flag patients that come in multiple times that seem to be seeking narcotics. And they don't kick them out or anything of that sort. They just send them a note saying, we're concerned about you, let me get you hooked up with a social worker, let me get you helped up, and try to reach out to make some difference and see if we can, and go on. That's an awesome start. Now we need to figure out how we can connect them to some of the treatment centers we do have and going on here. So we need to look at that. We need to then look at, and we've talked about housing, we've talked about employability. It's the whole continuum. And I do feel, I'm not naive that I know money plays a big part in a lot of different things, but I know a lot of us get our happiness from other things. There's always that study, does money buy happiness? And actually it does, up to a certain point. But once we get to a certain point, it hasn't shown to buy much, and we see many millionaires that are miserable. So there's also the aspect of what happiness of helping others and making a difference in the community, and I think this is something that many people they already are behind. We just need to see how we can even do this better and coordinate, and I really, really appreciate the Attorney General's leadership on this and the assistance from the Montana HealthCare Foundation. Thanks.
Hey, the anchor lap. So it's the end of the day, and I'm going to start my presentation by giving you the conclusion, and we'll try to wrap this up. But I think I want to start in a little bit of a different place. We're a young foundation. We're brand new. We've only been in the state for 3 years. I will say that behavioral health was absolutely the very first issue that we heard about that should be a focus of ours, and the most common issue to date that we've heard about in the last 3 years of traveling the state, working with partners, working with all of you. Behavioral health is a very serious issue in Montana. and so let's see if this thing will work, and if it won't, then I can even skip it. So we've already heard a lot of statistics, and I'm actually not going to start with statistics. Instead, I'll start with telling you I think there are really 2 core reasons that we work on behavioral health. The first is that we keep hearing how important it is. So the statistics are compelling, but it's also very compelling when, as Dr. Holzman mentioned, we work with health departments around the state who do community health assessments, and again and again and again, substance use disorders, mental illness are the top 2 issues that health departments hear from their communities ought to be a priority. The second reason that we focus on behavioral health is because, unlike the doom and gloom that we hear all the time about healthcare costs going up and not getting the outcomes we want, we've found tons of great examples. One of the things foundations like to do is, we call it bright spotting, and it's going around and finding examples of success and then seeing if you can replicate them in your area of service. And there are lots of great examples of people making enormous progress on this. What's unique in Montana, what I've never seen anywhere else that I've worked in a career that spans clinical care in urban areas in California, in rural Alaska, and policy work at the national level in DC and Alaska, is the kind of coalition that we've built in Montana. When you can have in this room a week ago the Attorney General of Montana, the Lieutenant Governor, the Director of the Department of Public Health, the Director of the Department of Corrections, the Director of the American Indian Health Department group that we help convene, all sitting together with 300 people in the room and another more than 1,000 online watching, all committed to improving prevention and treatment of substance use disorders. I think that you've got a fighting chance. I think you've got a running start at addressing this issue. So we're working on this partly because it's a big problem, partly because we know we can get somewhere on it. Our core strategy, the thing that you'll hear me talk about again and again and again, although I hope I don't use the words too often because I don't think the words are very descriptive, is integrated behavioral health. This is really just team-based care. It's the notion that instead of fragmenting care more and more for patients who have complex medical and behavioral issues, you put them all under one roof in a team-based, well-coordinated, monitored and care managed way. So you put, in other words, to make it simple, primary care, behavioral health care, care coordination, and disease registries or other tools for allowing you to track outcomes all under one roof, and you take care of those patients in a team-based way. There's lots and lots of evidence. There are dozens of clinical trials that show integrated care works. It improves outcomes and saves money. And yet it hasn't penetrated all that deep into our healthcare system. So here's an example. I chose Missouri because it's an example of a state that implemented this at the state level and really has seen some impressive results. They took what's called the health home financing mechanism that's available in Medicaid and implemented this in all of their community health centers and their community mental health centers. This means taking a behaviorist and putting that person in the community health center and taking a primary care provider and putting that person in the community mental health center. They have incredible outcomes across the board. I just chose a few from a presentation that must have taken 3 hours to deliver because they provided a lot of statistics. This is hospital rates, both on the community health centers on the left and the community mental health centers on the right. These were, by the way, this is a distilled patient population. These are people with serious persistent mental illness, so people who are high cost, high needs, complicated patients to take care of. They also found that legal involvement decreased by nearly 70%, that psychiatric hospitalization decreased by more than half, that illegal substance use decreased by 52%. This despite this system not actually doing anything to expand specific specialty substance use disorder treatment. It's just integrated care. We've been investing in this now for a couple of years. Most of the grants we've given to date have been planning grants to help systems begin to plan and figure out how to deliver integrated care in their settings. We have a few implementation grantees, and we're just beginning to see some early results. So I think it's very encouraging. One grantee, currently a primary care practice, already reporting in the first 6 months of implementing this that, first of all, for the first time, they've actually seen positive revenue. Second of all, that's probably partly because they're seeing a greatly decreased no-show rate. They have seen a 45% reduction in ER utilization already. Again, it's early, but it's very encouraging, and it matches what we've seen from much longer-standing national programs that implement integrated care. So I want to stop talking about integrated behavioral health because it's too many syllables and it makes it sound very specialized. We really view this as good care. This is, you could view it as, specialty surgery, as my colleague Scott at the foundation always talks about it. We're reattaching the head to the neck. And I think that though we should be not thinking of this as something unusual, we should be thinking of this as something basic about the way that we deliver care. So part of this talk was to go beyond just behavioral health and really focus in on substance use disorders, which is something that we've been spending an awful lot of time on. I don't think I need to go over more statistics on why this is a serious problem, but I do think I wanted to point out a few things that we found from our analysis of the delivery system. So we found that until the Medicaid expansion, the main way to pay for substance use treatment in the state was a federal block grant, the chemical dependency block grant, and some dollars out of the state general fund. HB 90, so the Medicaid expansion now provided just an engine, a way to pay for services if someone wants to provide them. HB 95 that passed in the last session also allowed more institutions statewide to begin providing these services. We heard last week that these numbers were pre-HB 95. There were 32 state-approved providers. So with that system, with the investments from the block grant, state general fund dollars, with HB 95, or pre-HB 95, with 32 state-approved providers, we were able to care for about 6% of Montanans that have a substance use disorder. Of that 6%, we know that drug use and pregnancy is a major problem. Only 1 or 2 of those providers were serving pregnant women or women with young children. So clearly not meeting the need for treatment. The other thing that we found is for medication-assisted treatment, which is a way to care for people on an outpatient basis who have an opioid use disorder or alcohol abuse. We have one of the lowest rates of people providing medication-assisted treatment and providers providing that service of any state. So some real delivery system issues. So our approach has been, first of all, to work on some of the policy analysis we've done. Second of all, to provide grants to expand access to evidence-based treatment. We're also working with DPHHS and with the Hilton Foundation to do a landscape analysis to look at increasing the use of screening, brief intervention, and referral to treatment. This, again, the way that I would look at this is that 50 or 60 years ago, we were beginning to talk about the silent killer. The silent killer was high blood pressure. when you went to your doctor's office 50 or 60 years ago, you might or might not have gotten a blood pressure cuff on your arm when you walked in the door. Now, if you didn't, you'd really wonder what was wrong with that provider because it's automatic, it's routine. We don't do that for substance use disorders. You aren't screened when you go into the ER, when you go into the primary care office. And because we don't really recognize yet, this is another silent killer. This is something that's affecting many of our patients. It's affecting physical health outcomes as well as behavioral health outcomes, and we're not screening for it. So we're looking at what could we do in this state to make it easier for practices to integrate this into the very long list of things they're already supposed to be doing. And then convening. So Attorney General Fox mentioned this. We were in this room last week talking about the same issue. It was a phenomenal meeting. I think I really want to emphasize this. This was a team effort. To have all of these agencies participating together in planning this event was unusual, and I think a very good way to start off what I hope is going to be a collaboration that really solves this problem. We had the listening sessions that Attorney General Fox mentioned around the state. We've done a lot of literature review, and then that all led to putting people in a room together to talk about solutions. I think what I really want to emphasize out of that is there are solutions, and this group agreed to some key principles for moving ahead. I think they mirror the strategic plan that Dr. Holzman mentioned, and they are largely common sense, but they're actually all specific actions that we can take that I think will make a difference within a year or two if we really put our weight behind it. These include, first and foremost, investing in prevention. Prevention is really underfunded in Montana and nationally. Prevention, most of the data suggests you're going to save $1 or save $10 for every dollar you put into prevention of substance use disorders. We can strengthen prevention in the state. There are some specific measures that we can undertake in partnership with local health departments, current providers, and hospital systems in our communities to improve substance use disorder prevention. Second of all is improving access to timely, effective care. So you've heard from Dr. Holzman that it's really a problem if you go to the ER, you're having a crisis related to a substance use disorder, and you get told that you have to wait 4 or 6 months to get into treatment. That's not optimal. Instead, we need to figure out how do we increase access, timely access, prompt access to treatment. We need to build a stronger continuum of care. There's a real emphasis on inpatient services. There's a role for inpatient services, but if you have inpatient or residential treatment and then you're discharged without a lot of follow-up or continuity of care or outpatient treatment, your outcomes are much less likely to be good. So we need to invest in the full spectrum, the full continuum of care, not just those higher cost inpatient and residential treatment services. And we need to think about using existing funding more effectively. So I think when you go into a community and you hear what the cost drivers are, you hear the correction system is overloaded, the jail is overcrowded, the waiting list for outpatient treatment is miles and miles long. So we need to think about where are we going to reinvest those resources so that we're getting the results that we want, and not just eating into everyone's budget a little bit more. So I think there's actually the opportunities for action are on our website. There's also a stack of them in the back corner back there if you want to pick one up. I'm hoping that this is something that the foundation will be partnering with each of the agencies on our steering committee to work on implementing in the coming years. And again, like I said at the start, there's absolutely no reason for us to think we can't make progress on this. This is a solvable problem, and I have every confidence that we will be back here in a couple of years talking about how much progress has been made. Thank you.
So thank you to all of you for all of your comments and statistics. So maybe what I do right now is open it up to the audience for any questions that you may have for any one of the panel members. Questions, or have we reached the end of the day? So here's one question I would ask for any one of you. There seems to be this fundamental issue when you talk about behavioral health of the stigma associated with mental health. How do we go about addressing that issue? I mean, there's a lot of other good programs, as evidence here of things going on, but there's still this stigma of mental health. You bet.
I'm going to have to leave. So I think several people mentioned the prevention aspect of what we need to be doing. And I would say it's prevention and education, along with trying to keep people from entering into the cycle of substance abuse disorders. We also, as I mentioned at the end of my comments, we have to raise the dialogue about what we're dealing with, whether it's just how substance abuse affects your brain, and we need to talk in context of individuals they have a medical illness. They're not criminals, even though they may have committed a crime. They're not substandard citizens, even though they have a real problem. It's kind of like the way we've addressed sexual assault in Montana through our office in bringing better outcomes, trying to prevent assaults, obviously, but making sure we have a trauma-informed, victim-centered justice system that instills confidence in particularly in people who become victims and are survivors of sexual assault, that they can trust their judicial system and that they will get the help they need, that they won't be blamed, and that they will be able to recover over time. And you do that not only by, as Dr. Holtzman pointed out, finding systems that work and that are evidence-based and fact-based, but raising the dialogue and talking about these. And it's not just public service announcements on TV or brochures that are handed out or information on websites. It's each and every one of us talking at the dinner table, at the conference table, in our churches, and in public about these issues. And when good Montanans raise the dialogue and do away with a lot of the preconceived notions and the societal bias, we make a difference. That's my 2 bits.
The one thing I would add on to that is I do think words matter, although I've also said the words that are probably wrong. It's just colloquium. I don't mean anything by them, but you've just gotten used to saying some of the things. And just among my colleagues in the sense of the healthcare profession, I think we need to get better about watching what we're saying and how we're communicating about individuals with mental illness, because many of them, they'll do great. And mental illness doesn't mean you're a bad person or doesn't mean that you're a risk to others. Most people are not. It might mean that they're suffering, they have some internal pain, and that we can help them with that. So, I think it's about being a caring individual and moving forward on that and just understanding what these individuals who have a mental illness bring to our society, because most of them are just wonderful people that bring in so many different great aspects to our community.
I don't have anything to add.
Okay. So does that generate any other questions from the audience? If not, okay.
Just a quick question for Attorney General Fox. A couple of things you mentioned, Mr. Fox, piqued my interest. Many years ago, I read some articles and was convinced that we need to decriminalize drug use and take it out of the criminal realm. And then since then, over the years, honestly, I don't know what I think the last few years. You're in a position in law enforcement to have a better perspective. Do you have any views on that?
So the 300-pound elephant in the room is always marijuana. and whether or not we needed to decriminalize that. Of course, Montana now has limited medical marijuana, and other states have recreational marijuana. And I'm a firm believer that we continue to see marijuana being one of the gateway drugs. And I know that's a catchphrase, but we see that through law enforcement, our judicial system. I think we see it in our health care providers and what they see in terms of people presenting to them. And so I personally think it was a mistake for those states who passed recreational marijuana statutes to do that. And I think they've seen a lot of unintended consequences, and it's hard to gauge the cost, the societal cost of things like children getting better access to marijuana. And I just read before I came in here, I was just reading a story about an autopsy on an 11-month-old baby who they've now determined overdosed on marijuana. And how and where do these things happen? It's incredible. The other thing that the DCI chief, Brian Lockerbie, that's our Division of Criminal Investigation chief, will tell you after 35 years of work as a law enforcement officer, is that as we saw more and more access to local marijuana, the Mexican cartels had to change their marketing system, and they eventually turned to methamphetamine, because they can produce it in high quantities, high purity, and they can sell it very, very cheap. And they now use a system where you used to have pushers and users, and they were rare, not so often one and the same. We now see a system where the users are the pushers, and vice versa. And you can get methamphetamine pretty much anywhere very, very cheap. And that's where we've seen this spike in Montana and other places in our great nation. And a lot of that, again, is because of the ease of accessibility to marijuana, and an unintended consequence that now a criminal cartel in another country has to change their business model to make money. So I think we have to be very, very careful. The other thing I would mention, and I want to thank the Montana Medical Association, who are here today, who've partnered with my office for the last 3 years, among others, pharmacists and law enforcement and others, to take a different approach on the prescription drug abuse prevention. But we find that there are so many people out there that legitimately need some way to address their pain, their mental health issues, or whatever it may be. And so we have to be very sensitive to that fact and careful that people don't slip through the cracks because we're so gung-ho about a particular course of action. And that could be said in any policy matter, I know, but it's particularly true here because we're talking about real people with real lives, with real needs, and we all need to be sensitive to that fact. I don't know if that answers your question well enough, but
I just want to add one other thing, and I'm not going to get into the legalization or non-legalization, but I just want to remind you, our number one problem is still alcohol, which is legal. So, we can talk about the different aspects, but we still have issues that are underlying that we need to get at.
Are there other questions? If not, how about a round of applause for our panelists?